For the first half, we really focused a lot on medication-assisted treatment and looking at the biological contributors to addiction. And with that, we really need to focus on the next half more about the assisted part of it. So what comes along with the medications, and more importantly for this time right now, is to talk about who's delivering this care. Because all this great research and all these great medications and interventions, when we start to really operationalize the great ideas into our workforce, that's really where we get that connection so that our patients and community members can really engage in treatment-seeking behaviors that work and that last, and they're willing to come back. So I am so fortunate to be able to introduce kind of what has traditionally been behind the scenes are some of the people that develop the workforce, they work the front line, and it's no longer reasonable to keep this information behind the scenes, but to bring it forth in a new way so that we can start to access people like this and say what works and how do we bring it into our recovery. I will let you introduce yourselves, but let me just do a little. We have Dr. Jessica Rodriguez, and she is the founder and CEO of Gateway Corp, a clinical director, clinical consultant, and lead clinical trainer, and lead interventional trainer, on-site strategies, and Gateway interventions. Additionally, the founder of Art as Medicine. So thank you so much for being here. And TJ Woodward, he's the founder and CEO of Conscious Recovery. And the creator of the Conscious Recovery Method. And also we have Dr. Adriana Popescu, who's a licensed clinical psychologist and empowerment coach and clinical director at Avery Lane. Thank you. So I am going to ask a few questions from our panelists, but before I do, a little bit of context as to looking at the psychosocial side of addiction. And so we talked earlier, I think Dr. Aragon brought up the adverse childhood experiences. And if we could take a step back and think about those adverse childhood experiences and times of first-time use. Because when those children are experiencing things that don't feel well, and they don't feel like they belong, or they feel different, and they reach out to something that makes them feel better, I don't think that they were suspecting or expecting that it would lead them down a path of becoming maybe homeless, or ending up in places that they just didn't think their life was going to go. They were just looking for something that could make them feel better. And so if we're going to really look at addiction, we would be so short-sighted not to think about what works well. And addiction rather than being resistant to change, taking a deeper look at being addicted to the status quo and what that looks like for our patients. And I think you're going to hear today shifting that perspective about maybe part of your addiction was brilliant. It was a solution that worked for you for some time. And then at some time it just didn't work anymore, or it had unforeseen consequences that became a trap. I think as we're also going to take a deeper dive into trauma-informed care. And while we have an epidemic of addiction, and first-time use may be down for adolescents, but suicide is up. But when we look at another epidemic, it's our workforce. Our workforce right now, especially, does anybody raise of hands of who's actually in the healthcare workforce or they're treating? So our workforce right now is experiencing burnout, right? No, I guess that's not too exciting, but so 1 out of 3 nurses are leaving their love of nursing within the first 3 years of the profession. Medical doctors are leaving their love of medicine early and retiring. And when we start to consider that a disengaged workforce is really a prohibitive piece of the puzzle when we're working with patients that have self-managed conditions. When they arrive in their primary care setting, maybe a patient-centered medical home model where they'll have a warm handoff to somebody that can help them with their emotional conditions that they're curious to learn more about. When they have a disengaged workforce, we miss something. We don't connect. And we can't all be part of the Haight-Ashbury Free Clinic in 1967 where we volunteered and we just showed up because we have so much love in our heart and we want to be non-judgmental. But we have to be more strategic now, and we have to learn what are the ways that we can protect our workforce from not just acting on emotions and what we think are good intentions, but we need a framework to keep us safe so that we can rely on a structure so that we don't get burned out. This workforce must be protected. And if we're going to develop a workforce that's more adequately prepared to treat addiction, it's learning about what it really means to be inclusive. And when we're gaining some steam about being non-judgmental about skin color or gender or sexual orientation, there's another area that needs to be focused on. And it's about neurodiversity, and it's about accepting people that their personalities are a little bit different. And it's those moments, so many of you raised your hands, so many of you might have had that experience where you're running a group therapy session, and somebody gets up and throws a chair. Or they just said, I'm freaking out of here. This sucks. You guys are all a bunch of, those moments where people in this room, we don't roll our eyes. We don't side talk and go, shh. We just kind of say, we've totally been there. They'll come back. This is a safe place. But if we don't have that kind of training, and these people are going to bring it out, how we can get that training in a more synthesized way, then we're at risk of severe burnout, and it really just jeopardizes that patient care. So I'm going to ask first I'm going to let you introduce, if you would, yourselves and where you work and what you do, and then we'll go into some questioning. Thank you. Okay.
Okay. I'm Dr. Adriana Popescu. I'm a licensed clinical psychologist, and I've been in the field about 25 years. My specialty is in addiction and trauma and energy psychology, and it's that more holistic approach that really drew me and TJ together to kind of begin to collaborate on some of the conscious recovery stuff, which we implement now at various rehab centers, including Avery Lane, where I'm the clinical director.
I'm TJ Woodward. I've been working in the field for over a decade, and what I want to say just to right out of the gate, first I want to acknowledge Jason Schiffman for being amazing, and thank you. One of my favorite people to be, I can hang out with him for 4 hours and be in conversation about this, and the reason I'm starting with that is that I quickly recognized, starting in this field, that there is a physical, mental, emotional, and spiritual aspect to both addiction and recovery. I also quickly realized, beginning to work in this field, that most of the modalities were focusing on symptoms and behaviors without really getting down to what the deeper root causes are. And I want to acknowledge you because you opened up so much of what I'm really excited about and hoping that this conversation, where this goes. And about 2 years ago, I created the Conscious Recovery Method, which we're going to explore, but looking at how we can create a space and hold a space, and that's a conversation that I'm very passionate about, that will assist our clients in breaking the cycle of their addiction. But I also want to say this before I pass it, and that is, what if this work could be energizing? What if we can hold a space where we can be in the room and allow what's happening in the room to actually energize us rather than deplete us? So I'm excited about being here and so grateful to be part of this panel.
I'm going to say that too. Kudos. You are so amazing. I kept telling Dr. Mayo, you can let him go. He's answering all the questions already. Anyway, my name is Dr. Jessica Rodriguez. I was a hope to die dope fiend, homeless in Oakland, San Francisco, and anywhere I could find a car with a key and get to when there weren't any drugs available. I've been clean 27 and a half years. It took a bullet to my heart and a sudden death. Did you get it? So what I want to say is I've been a doctor since 2004. After the drug epidemic, I was pregnant with twins, and I wanted their life to be different. And so I went to school, became a McNair Scholar and a U.S. Scholar by the time I left, and got another doctorate in 2008. And Gateway Corp, we're a nonprofit public charity organization, but Gateway Corp stands for Center on Restoring Purpose, CORP, Trauma Informed Care Center. We lead with power therapies, which is EMDR, a kind of EMDR, brain spotting, which is EMDR on warp speed, like way warp speed, and somatic experiencing and person-centered therapy. And we're very holistic, and I love that you said that. And On-Site Strategies is one of the largest CEU training companies in the state, and I am only one of 2 trainers who's allowed by CCAPP to train interventionists in the state of California and to certify them. So it's my kids who motivated me because they're just amazing.
Great, and welcome again. So our first question, it focuses on when we're working in the field and we have those we have a front row seat to change. And it is an amazing experience. And often, I think I'm not alone, where we leave our day of work and we think about all the things that we could have done differently or that we will do next time. And we start to become really dedicated to a shift in our practice where we start to develop some grounded theory. And evidence-based interventions, they have their spot, they have their place, but we're moving so fast right now that when we take evidence-based interventions and we evolve them to include grounded theory and have that first-line experience about what we're seeing, we start to come up with innovation, something different, something that works and something that's catchy. And so, Dr. Popescu, let's start with the first question for you, if that's okay, is in your practice, what changes have you observed as a result of bringing your work to the field?
So I can speak to it a couple different ways. And I think they're both synergistic. So using energy psychology tools, maybe things like EFT, those of you that are familiar, tapping, things like that. When you include the spiritual components, which is also the work I do with TJ, and you're looking at addiction, depression, anxiety through the lens of physical, mental, emotional, and spiritual, you have to address all 4 of those components for somebody to really be able to heal. And the problem I see with our system is that it's really fragmented. You go to this practitioner to deal with the physical. You go to this practitioner to deal with the mental and emotional. And the spiritual, if it gets addressed at all, maybe you go talk to your priest or go to a meditation group. And rarely is it that we're looking at all 4 of those. So I think that is so critical for us to be doing that. And when, having worked in addictions now for almost 20 years, when we start including the spiritual and we come at it not from labels and pathologizing, which I know TJ will talk more about it, but more from a strengths-based approach. Like, what if actually you are not broken and defective? What if you're not doomed with this pathology for the rest of your life? When you show people that change is possible and you start speaking to them about their strengths, what if there's nothing inherently wrong with you? There is a hope that emerges that energizes not only the clients, but us as the practitioners as well, when we're not constantly having to look at what's wrong with people, they're so broken, how do we fix them? There's no hope to fix them. There's no way they'll ever get better. They've been in and out of rehab 22 times. What's going to be different this time? But when you start speaking to them in this language of, you are whole and perfect as you are, then something lights up in their world. And when people come out of the conscious recovery groups, they're so happy and they're smiling and they feel like that bright, shiny little kid they once were. They start to access that part of them that was brilliant and whole before the trauma, before they got conditioned, before they got disconnected. So that, to me, is what motivates me to want to keep doing this work when I see that we get those kinds of results.
Thank you. And I think really combine, like you said, a synergistic effect and really bringing different modalities together and not just sticking to one intervention. And that's something that when we go into a setting where we're working with patients, we have to explore and push the envelope a bit and make space for us to create. And so, TJ and then Dr. we have a few minutes if you wanted to add anything to that.
Yeah, I wanted to share a little bit of my own story because when I started working in the addiction treatment field a little over a decade ago, I started with a fundamental question, and that question is, what if underneath all addictive behavior is a whole and perfect spiritual being? And I want to share how I came to that question and how it informs the way I work with clients, and then I'll share a little bit about the impact that that has had and what I have witnessed, profound results in the quantum field. I'm going to talk about the quantum field in a moment and the observer having an effect. I came into this world and I remember being a really small child and being absolutely filled with joy. And I remember laying in my backyard mesmerized by life, mesmerized by a blade of grass, looking at a butterfly and just my mind blown of what or who or how this all came to be. I also remember when I started to lose that experience, and it came through growing up in a household where what I was hearing, what I was seeing, and what people were saying were completely incongruent. There was a lot happening in my household that created an experience of me wanting and needing to close down. And at age 7, I remember like it was yesterday, a physical sensation of closing off. I have actually come to reframe some of the common language. I know Jason Schiffman used the term coping mechanism, but I actually do call them brilliant strategies, because that was an unconscious strategy that protected me at the moment. Of course, the issue was it protected me from love and connection. What happened, of course, is I walked around feeling broken, disconnected, filled with shame. Something's fundamentally wrong here, until I discovered weed and alcohol at age 13. Got sober 33 years ago, just before my 21st birthday, which I don't really want to acknowledge because then you do the math. But I just want to say briefly that what really changed me was an observer, a woman named Mary Helen Brownell, who witnessed me as a whole and perfect person when I could not possibly do that for myself. So I can share more later about the impact of the observer, but what I want to say about that is when I hold the space for a person to experience their own spiritual wholeness, something profound happens rather than pathologizing. I know we're going to talk more about that.
Thank you, TJ. It's a brilliant strategy to engage in a behavior that made you feel whole. And yes, it does dampen the ability to feel whole with love, but it is a brilliant strategy. I like that. Very impressive. Dr. Rodriguez, we have a minute or two if you wanted to add to that.
God, it'd take me 30 minutes to say what I want to say right now, but I won't. Take me about 30 minutes to say what I need to say in a minute or two. I'm going to kind of switch back and say these questions. She is phenomenal how she created the panel. The question is, panelists, to remember, what drove the need for change you bring to the industry?
Okay.
Right? Number one.
Well,
right?
So
Was that
what kind of things have you seen in bringing trauma-informed care into your space? So what kind of changes?
Oh, okay, got it. Well, I don't do treatment like a lot of treatment providers do. I do treatment based on getting some of the most difficult people that come in our office are so rich it's disgusting. And most of them have trauma. They were ACEs kids. They're not ACEs adults. They're ACEs people. They're individuals and people that have lost their way based on how they still live. And because of a trust, and a lot of these individuals have really, really severe addictions, There's secrecy. There's a lot of sabotage within the family. We're not doing anything not to get that money when it's time. So I really had talked to Dr. Smith because ACEs, Adverse Childhood Experiences, and if you don't know what that is, go to TED Talk and look up Dr. Nadine Harris-Burke. She is one of the best. Really study ACEs. And the other piece is First Impressions, CDC, Kaiser, YouTube, and really look at an ACEs full research video. Adverse childhood experience, for me, we utilize the assessment sheet, actually. That's where we start. We want to know who they were from the womb out and what their experiences were so we can look at how they got to where they are and their family systems. We train family systems. As a CEU provider, we bring the most cutting-edge, relevant trainings to California that you guys would be surprised that we have them. You're good?
Thank you.
Okay.
Yes. So thinking, taking it a little further, when we look at some of the irreversible consequences, the devastating consequences that we see right here in San Francisco, the homelessness and the needles on the street, and so much need to address the public health, the root causes of systemic public health problems. More than ever, healthcare has adopted best practices from other industries and business models, like really looking at a root cause analysis and being more efficient and effective with resource utilization to make sure that if we are going to invest money towards a public health problem, that we've done due diligence to understand that we're not putting Band-Aids on symptoms. And this next question really takes a look at that when we're looking at the acuity of addiction and in the moment, treating something and triaging effectively. We have to be very wise. There might be just a window. The public health messaging here is that we want you to come in at any phase of your experience so that we can meet you where you're at and we can move towards a harm reduction model. So this next question is, in your work and your experience, what role do you believe or have seen that going to the root cause has been a part of your work? And then what role do you believe that you've been playing in that work of root cause and looking at that? TJ, would you start us off?
I would love to. So I want to shake it up a little bit because I have, working in the field for quite some time, I think we have in many programs kind of a cookie cutter approach to how we work with trauma. And I think we've heard throughout the day of trauma being such a deep root cause. And in conscious recovery, I identify the 3 root causes of addiction as unresolved trauma, disconnection, spiritual disconnection, and toxic shame. So if we look at kind of the cookie cutter approach that has been rolled out in many treatment programs, and I understand why, and that is we can't really work on trauma because we only have you for a certain number of days. Maybe the insurance company is only going to give us a certain number of days, so we're not going to work on your trauma. That's great for quite a large percentage of our clients. And there's this other huge percentage of clients that are coming back to treatment over and over and over again, and trauma and shame are such a root cause that we're actually in malpractice if we're not creating a space to work on the trauma. And so there are now programs like Avery Lane, a healing center for women, I think I got that right, who are really working with people with their trauma. But what I want to say about my own work with that is very simple, and this is an invitation. Holding space for a client to go into any of their deeper unconscious biases, beliefs, and ideas. In other words, the shame that they experience. I'm not going to be able to allow the client I'm sitting with to go any deeper than I've gone myself. So the number one thing I can do to provide a safe space for clients to work on their shame and trauma and disconnection is to work on my own. 100% of the time, because the observer has a profound effect. And this is the last thing I'll say. You know, we know now, of course, that life is energy, and that table is actually compressed energy. It's not solid. And we commonly say that about 15% of communication is verbal, but I hear a lot of people saying the rest is nonverbal, of course, body language. It's mostly energy. We are all an energy field. And when I'm in the room with a client and I am afraid of my own shame and my own unresolved trauma, I will create an energy field where they can't possibly go there. So my invitation for each of us is, if you're in a place where you're saying, I really don't want this person to go into their trauma, what if they do, what if they come undone? What if they come unglued? What if they dysregulate? Of course, we need to have a safe place for them and hold a container, but I think the invitation is for me to do my own work so that I can allow a space for them to begin to look at those deeper root causes.
Wow, that is excellent. Yes, thank you. Thank you. And humans are hardwired for connection, and when we start to look at those child moments where we're seeking connection and we reach out to something, and I wasn't planning it, but I want to disclose something that I remember when I was young and had that experience of not feeling like I was enough or that I was judged, didn't feel it fit in. I remember going to see the Grateful Dead at the Greek, and I hated the music. I was like, oh my gosh, this sucks. They're all quiet, and like I wanted a rock concert, like the Grateful Dead. And I kept coming back because it was so much connection and so much love and so much sharing. And I think that our experience with music up here earlier said so much, is to just create a space. We're not, taking the identified patient out, putting it under some grow lamps and putting it back in the bad soil. It's kind of a bad analogy, but you know what I mean. But I think we really are creating that climate. And I think that's, you summarized it so well. I would love to hear from you and Jessica as well about that.
Yeah, I mean, with regard to root causes of addiction, my own personal experience as not necessarily someone in recovery, but as somebody who went through many years of an illness, the mysterious illness that nobody could identify. Western medicine had no answers for me until about 13 years into my struggle, which turned out to be Lyme disease. So I had to seek elsewhere. Because all that Western medicine could do was try to medicate my symptoms, and that wasn't getting to any root cause of anything. So it was in my seeking of alternative medicines and spirituality that I began to discover unresolved traumas of my own, disconnection of my own, ways in which I was seeing myself in the world. I had to look at all that stuff, and when I started becoming conscious and challenging and reframing and changing all of that stuff, that's when I started to get healthy. So I learned from that in working with my clients with their mental health and addiction issues, I need to take the same approach. So for what I've discovered, and especially with the conscious recovery material, absolutely those are root causes of addiction. And really the primary addiction is to self-judgment. That even the substance use or the addictive behavior is secondary to that, because it's by judging yourself and living in that toxic shame and that sense of brokenness, defectiveness, which then of course creates the disconnection. As long as you continue to think in those ways and see yourself in those ways, medication is just a Band-Aid, not even just not using. I mean, that helps, but that still isn't getting to what's really driving the behavior in the first place. And if you get people to start seeing themselves differently, and you are looking at them differently, not as broken and defective, that's the space in which the healing can occur. And then the need to go do the addictive behavior starts to fall away.
Thank you. Thank you so much. Like a minute or two? Okay. Yeah, I'd love to hear what you have to.
I want to just kind of be TJ for a second. I just sat here and kind of my mind blown because people don't really want to talk about how our industry is still siloed. We've got substance use disorder here and mental health disorders here, but yet all of it's in the DSM-5. But we're still doing the cookie cutter approach. Many times, But I'm going to take a chance here too. A lot of that is based on insurance. So let's keep it real. It's insurance and grants. Keep it real. When it's done at the cost of the client, just like she said about, God, you said so much I can't even remember it. Here's what I want to say. Everyone is entitled to best practices. We also have laws that have been in effect since 1965 about disparity, cultural linguistic appropriate services. Most agencies don't comply. There was a gal out of Altamira, I think it was, or Bayside or something, that came and talked to us at a dinner in Sacramento about the LGBTQ community. I thought, heck, I would love to be a lesbian and live there because it's so inclusive. They're not just, men aren't just here and women aren't just here. Well, most of this population is LGBTQ and they're comfortable with who they are. The last thing I'd like to say, one of the reasons I've taken this rather holistic approach, and I've been living an Ayurvedic lifestyle, and I've been a Christian senior pastor forever, I almost got killed behind Dr. Rodriguez. Are you going to that shop where they have gurus and the statues? I said, it's really none of your business. It's about my health and my lifestyle, right? I went to 13 treatment programs. None of them treated not just my addiction, how sick I was from a child until I got clean at 40 years old. And one thing, I know what you said that really pulled something up. Oh gosh, here we go. In the field, and this is not a judgment because I'm a perfect person, but I'm going to tell the truth. We have far too many people working in the field who are not qualified to work in the field because they haven't done their work. Like TJ said, if you haven't done your own personal work and you haven't dealt with abuse, rejection, separation, foster care, incarceration, whatever it is, and you go into a session, 99% of those people are going to experience something where we've agreed to do no harm, but we can project, we can get into countertransference, we can misdiagnose. You know why? Because our sickness is where we're coming from. It's a kaleidoscope. We cannot see it clear enough. And if you dealt with the levels of abuse I did with 6 pedophiles from the time you were 3 till 12, and you had abuse and abuse and abuse and abuse, if I hadn't done my work, you guys wouldn't want me to work with anybody because I was too sick. So I did my work going to school, and I did my work so that when I had those 2 girls at 40 years old, I could finally be a better mother. Okay? Done.
Yes, thank you. Thank you for that.
You're welcome.
So I'm going to skip a question here. So when we look at the workforce and we focus on workforce development, it's no longer reasonable to keep mental health locked behind the healthcare landscape because there's a kind of a thinking that we all could benefit from some of the phenomenal interventions that people that have inpatient experiences or facility, everybody's recovering from something. And our cultural landscape is changing so fast that our value systems and how we look at really giving that message to our families of inclusivity. And how do we deploy some new thinking so that we can work better together with all of the diversity that our children have and that we have in our workspace. And so when we talk about a trauma-informed care team and our loved ones or ourselves, we're looking for treatment centers, it's talked about freely. Not always is the care team trauma-informed effectively, but beyond the healthcare landscape, how can we become families and educators and community members that take a broader lens to bring a humanistic approach to everybody that we work with, so that we can start building a trauma-informed world. And when we look at some of the criteria to be trauma-informed, it looks a lot like how can we bring world peace? I mean, it really does. It's about inclusivity and understanding one another, creating, whoops, my battery went out. Creating safe spaces. Is it on? Yeah. And so my next question really focuses on trauma-informed care. Jessica, I want you to start us out, or I can go to TJ. So with your work in workforce development, creating trauma-informed groups, faith-based organization, et cetera, what do you see that needs to happen so that we can more rapidly adopt trauma-informed workspaces and cultures that we're living in?
I'm going to go a different way because I know that the two of these individuals are going to have the answer that really is aligned with what she's asking. I'm going to go somewhere else. Ready? I'm radical. I'm almost 70, and I'm super radical. So, thank you. Thanks. So, oh, here we go. Sorry.
Let her go.
Okay, I'm doing it. In Sacramento County, now, and I'll get real quick through it. I know we're limited. In the last 3 months, I have been a consultant, used to be one of the top ADP trainers in Sacramento. The audits, the fraud, going into companies, looking at things. Here's where we miss it. I don't miss it, but where I see a lot of people miss it. I'm very involved with CCAP and the complaint processes and all that. How many of you know that there are a lot of people that work in our field who don't have credentials? They say they have credentials, they say they're certified, they say they're licensed clinicians or doctors, but how many of you know that there are so many that are not? How many of you know that? I can tell you this month alone, I had someone who's not a PsyD, who's never even went to college, wanting to train for me. But see, I got a weird way. I need a copy of your credentials, and then I'll see if I can schedule you. They didn't exist. The other person was a KDAC 2 and an IS on the website, the business cards. I don't have a credential. I just call Pete Nielsen, the president. He says, Dr. J, we've never done it. So this is a big problem, is we take people for face values, and a lot of people we're working with, like Mawa, have been dope fiends in prison the whole bit, and they're good at masquerading. We don't really look at who is it that is treating our patients and clients in our treatment programs when they are not outside the scope of practice. There is no practice for them. They don't belong in the field. And so I'm putting that out there because I don't know if you got one of those little white packets. Thanks to Dr. Mayo, I brought them. She didn't know it, but we had all put these together. You want to grab one if you have one on your table? It's full of trauma information. Defining defining mental health from the public health system. And you can grab one that's left. And there's information about who are you, about credentialing. I find that there's a problem in our field where there are too many people who are not in a position that should be doing anything, but too many people are afraid to report it because then it's snitching. Well, what the heck is snitching? Did we not sign an ethics complaint to report these things? Absolutely. And it's our responsibility, and the only way it'll change is if we do something about it.
Okay. Thank you.
You're welcome.
So I want to summarize a little bit. I think that definitely having the right credentials and the right training is so instrumental in the work that we do. And that what we're noticing is that we need to develop a workforce that is inclusive of individuals that can be peer counselors, that can be advocates, they can develop, be part of that well-developed support system. So I think that it's important for us, and I encourage us to expand our consideration and how we determine what works best for our families. Because sometimes people have all the credentials, but their heart isn't in it anymore. They're burned out. And so sometimes the unsuspected person is the catalyst to help our loved ones get into treatment. And so a comprehensive approach is really, I think it's a good space. It is a good space. And so I would love to hear from both TJ and Dr., both of you, on trauma-informed care, bringing this work, not trauma-informed care, but also bringing the work that you do. What do you need from this workforce in order to start operationalizing these great ideas and bring them into the maybe standard of work, more mainstream?
Well, I mean, I think it's just echoing what you both have said, doing your own work. One of the things we do at Avery Lane that I think is a little different than other programs I've certainly worked in is that we give the clinicians, including the line staff, the residential counselors, all the same skills that we're giving the clients. I have staff come and sit in on all my groups. And whoever's available can sit in, get the handout, participate in the exercises, and learn what it is the clients are learning, not only so that they can support, because of course, the clients are on their best behavior when they're, at the center and in sessions with me. It's when they're riding in the van or at a meeting that they're having their meltdowns and breakdowns and all that. So not only by having the same tools the clients are learning, can they reinforce what's being taught in groups and in sessions, but then they also get to do the work on themselves. So when they're feeling triggered by a client's challenges, when they're feeling burnt out, they get to use the same tools. And I think that level of congruence across the board, where even, the person who's here with us today who works at the front desk is learning the same tools that everyone else is learning, that's when we are operating as a unit that works together, not all opposing different things.
Thank you.
Yeah, and I want to answer it in a couple of different ways. First, from an experience, and just a shout out to anyone who works full-time in private practice. I applaud you. I can't even imagine what that's like, because to me, what really is the most beneficial is working with a cohesive team and being able to have a safe space to reconnect with ourselves, right? And a safe space to talk about what's really going on. I've worked in programs where it is said, we come into this particular meeting where we can talk about what's really going on, but are we really? And I've worked at programs like Foundation San Francisco, where people really do have a space to talk about the experience of what it really means to be working with our clients. And the power of that safe space, to me, is so energizing. And I'm going back to this theme because it's so fundamentally important to me in the conscious recovery method in day one of the training, because I go into treatment programs and train clinicians and counselors. Day one is all about what it means to hold a space, not only for the clients, but also for energizing ourselves. And I'm repeating that theme because I think it's vitally important, because we talked about burnout. I know for myself, because for about 3 or 4 years, I did 4 90-minute groups, clinical staff meeting, and 2 individual sessions every Wednesday at Foundation San Francisco. And most of the time, I felt really energized by that. Now, my body felt tired, but I noticed that if I had a perspective that I'm the one with the answers, I felt depleted. And if I was willing to be in the room and live in a question with the clients and hold a space, knowing that inherent within each of us is not only the ability to heal, but that's the fundamental truth of who and what we are. I actually really want to shift the conversation in the addiction treatment field from addiction treatment to addiction healing. And what I've noticed is when I'm willing and able to hold a space in a group, I have the honor of doing 8-hour workshops at Altamira. I'm energized by the end of those 8 hours. Energized, right? If I were to be there with the perspective of, gosh, I really need them to get this, because I've done it, I have done that, I'm burnt out.
Thank you. And thank you for shifting us into healing rather than treatment. It's very helpful. There are a few things that each of us see when we're in our group sessions or working with clients that we kind of have that home run. And a couple that have been for me is really thinking outside of the box and grabbing their cell phone and downloading apps, or going out on a walk when they're an inpatient psych and they're not allowed to leave, but just pushing the envelope and saying, I got this, we're gonna go get some fresh air. Or just sitting down and connecting and, talking about something that's completely, seemingly unrelated to what they're actually there for, but letting them explore and imagine with somebody and just be, quote, normal for a moment. I don't even like to use that word, but just outside of the treatment setting. And so I'm very curious, with all the experiences that you all have, what are one or two things that you would say that you've seen that have stopped the cycle of addiction? And TJ, would you kick us off?
I thank you. Something so powerful happens for me when I'm willing to see the person not only as a complete human being, but also a complete spiritual being. I love what Jason Schiffman shared about the DSM. I think it's a very, very valuable tool. But as he identified, and I was just jumping up and down with joy because he's identifying that it's simply a cluster of symptoms. And so we can take these symptoms that are happening, we can call it this disorder. And I tend to be more curious about what's underneath that, right? There are these layers. There are these layers of these wounds, or as I like to call it, woundology, right? And many of our clients are living with this deep sense of shame or disconnection. So if I'm willing to be the space to hold for them of this wholeness, and I promised I'd talk a little bit about the quantum field and quantum mechanics, because what we know now is the observer has a profound effect. And what I'm looking for actually creates what happens. I'm not saying I have the power to heal the client. I don't want to come from that place. But what I recognize is if I'm looking through only, and I want to be, I also want to say, I know many of you in this room have been trained and you have a license and you are required to diagnose and treat. That's great. And so conscious recovery it doesn't have the answers. It's just one other opportunity, right? So as we've identified, physical, mental, emotional, spiritual. In this spiritual room, when I hold a space for this spiritual wholeness, it's remarkable what shows up. When I worked actually at Altamira full-time as the spiritual director many years ago, I was the person they called in to be with someone in what we call emotional dysregulation, which we know is a meltdown. And the meltdown rarely, if ever, has anything to do with what the trigger point was, right? Which is why I've reframed triggers to activation, because something's getting activated. Brief story, a woman was asked to move from the top floor to the basement. She had a meltdown. I sat with her through holding a space and simply being present with her, knowing that there's a space here for healing and wholeness. She had a memory of being sexually abused in the basement of her home. First time she had that memory. If I had simply addressed it from the symptom, which is, let me see if I can help you get to a different room upstairs, that opportunity would have been missed. I didn't know that that's what I was working with, but because I was willing to simply hold a space, it happened, right? She was able to get to that, and that's really where her healing journey began, because then she wanted to leave, right? She had her bags packed, but because of that, she recognized that she could actually then begin her healing process.
Excellent. So really creating that space again for healing. And
I mean, there's so many pieces, we need to address, right, when we're working with someone with addiction and mental health issues and them recovering from that. But I would say, coming back to that idea of the primary addiction being to self-judgment, when you get people to start seeing the power of perception, when you get people to start seeing themselves a different way, and if you're embracing what TJ is suggesting about you seeing them differently and you seeing them from a whole and perfect lens and seeing yourself in that same way, the ripple effects on a quantum level, mirror neurons and all the stuff we know now is like if you're being that energy, the change gets created organically for them. And then that change in turn affects everyone they're connected to. And when you talk about world peace, that's actually how it happens, is from the change one person makes internally and how they see themselves and the world around them.
excellent. Thank you. And Dr. Rodriguez.
It's my own belief that, the only one, oh, sorry, I talk so loud anyway. Like growing up in the hood, you just talk loud. So I believe that the only one who can create a narrative is a client themselves. I can't create their narrative. And so do I have the capacity not to navigate like they taught me in school where I'm running a session? No, I want the client to navigate their session. And that is why I love brain spotting. One session, 2 hours, you can have a particular trauma fully resolved. So with that, we're like, wow, we're rolling over here. I don't really think I have a lot to say because I'm so stuck on things you guys are saying. This is blowing my whole thing. I mean, you guys are amazing. Oh, Avery Lane. That's what you said about Avery Lane. I'm not into treatment. I'm a public health doctor. My supervision was Dr. William Glasser until he passed away. And I'm trained by Dr. David Grand out of New York in a mastery level. Little old sick dope fiend me is really working every day because I work hard at my own trauma every day. But I'll tell you what, if we can move from a mindset of treatment and even speak about treatment to heal, I want to have the capacity not to just focus on treatment. I want to focus on them healing and living an extraordinary life like I live. Okay, that's it.
Thank you. So great information. We're pushing the envelope. We're learning new things that we can bring to our clients. And so we have a few minutes now for all of you to ask some questions. And really, what we are trying to do is bring these newer grounded theories along with evidence-based interventions into the settings so that people can have easier access to care. And it's the right care at the right time, but care looks different to everyone. It could look like playing music on a stage, and it could look like laying in a really cool room doing ecstasy. I mean, it looks different, and exploring what that looks like. But I think I would really like for us to think of some questions because these people are doing it, and they're not behind the scenes anymore. They're making it accessible through workbooks and reading material that goes far beyond the healing center of substance use or chemical dependency, but into different faith-based organizations and academia, places where people recover all the time. So being expansive in how we consider bringing this work into our communities and not siloing it into just recovery. And so I'll get some help in bringing mics out, but just a few questions that you could think of for our panelists. Is that okay? Okay. I'm going to go bring this out. You want more? Yeah, and if you want to say a couple tips or talk, it's fine. You have to share your mic with
I love Dr. Mayo. Oh my gosh.
Thank you. Yeah, I just want to say thank you so much for the work that you're doing, for the reframing that you've offered for a lot of us. I resonate with a lot of what each of you said in my own recovery and how I've worked with others. I guess my question is, a lot of what each of you shared and what's kind of been shared here in this conference is outside of the box of Western medical practice, healing, how we think of ourselves, stuff around shame, responsibility, treatment versus healing, all this stuff within the rhetoric. I found that in my own healing, in the way that it's resonated with what you've shared, I've really had to strip down some of the structural traumas and social traumas just of existing in this society, let alone any marginalized identity I might have in specific familial traumas. I'm wondering how much time you spend with your clients and people in your community making that explicit. So I guess kind of just like how, I don't want to use the word political, but it's there, like how political do you get with this and how much do you feel that being explicit around that and becoming an activist in a visible social forum is an important part of healing communally as well as in the one-on-ones on the ground where you're working?
Yeah, I'm happy to take a chance at that one, or I'm not going to say a stab. We need a new language for that. Thank you. And I'll say something slightly controversial, right? It's an inside-out job, right? And so a lot of times what we call political is externalizing the internal work, and I understand why it is that way. I also want to say that, in conscious recovery, when we get into the breaking the cycle, we start with creating safety as the important first step. Safe community, safe relationships. Ultimately, this is about a safety, internal safety, so that I can begin to be with myself in a new way, and then moving into unlearning. And I think what I'm hearing you say is a recognition that, I'm not a big fan, by the way, of the term big T, little t trauma. I don't want to minimize anyone's trauma, because being born into this world, for example, as a little gay boy in Indiana in 1965, I had trauma based on I was just being me, right? And there was familial trauma, generational trauma, and cultural trauma that came from that. And I remember a very strong sense of it's not okay to be me, so I closed down, right? So operating under the assumption that all of us, because we're born into this culture and this time and space, that we have what I call spiritual trauma. And all I mean by that is we are not seen as our whole and perfect essential spiritual self. So holding a space for that, I don't know if I'm completely answering your question, but I think it's fundamental to hold a space, and I keep going back to that. I guess that's the theme for me today. But it's to allow someone to begin to explore, because as Dr. Adriana said so beautifully, ultimately it's about the self-criticism and self-judgment, but it's not just from the mind. It's that I have a nervous system now that's shut down because of the trauma, because of the generational trauma. And what we know now is that 7 generations back, we're carrying the trauma from our family. If I think about that, 140 years roughly, there's a lot of trauma. There's a lot of cultural trauma that's happened because of our race or orientation or gender in our culture. So even though it could be political, it's also deeply individual as well.
Yeah, I would just echo that and add the word empowerment. Like when you start to empower people to love themselves and honor themselves, they naturally want to do that with others. So again, yeah, the inside job, and then empowering people to destigmatize. I mean, there's still in the culture at large, we still have so much stigma around what it means to have an addiction or to have a mental health diagnosis. I think the clients, when they start honoring themselves and seeing themselves as beautiful, whole, and perfect, that in and of itself speaks to that destigmatization, and they're showing the world at large a different possibility just in how they be and how they live, without even having to necessarily take specific, what we might call political action. If they choose to do that, that's great, but I think live in honor with who you truly be. That will create a change in the world.
Thank you.
Question back here?
Also want to say thank you to you and to all the folks before you and those still coming. As somebody who's been in the field for a number of decades, I'm thirsty for this, and particularly so, I think, because in the last several years, in order to take care of myself in the work, I kind of stepped back from, I'm a nurse, psych mental health nurse, and I kind of stepped back from the usual places where psych mental health nursing works. And I now visit veterans and their caregivers, guys and gals with PTSD and TBI, in their homes all over the northern part of California, from Fort Bragg to Folsom and Mendocino County and down here as well. And it was an effort to gain some autonomy, to have the space that I needed for me in my practice. Because I wasn't feeling it, in the conventional work setting. I get to do what I love to do and what I think I'm pretty good at. And I want to just sort of say these things. This doesn't sound like a question, but I want to say these things to remind the folks in this room that more and more we're using technology. I know we're going to be talking about technology in a bit, to bring folks in who can't get treatment in the more urban places. For our veteran population, a lot of them are coming home to rural settings. And as folks have already talked about, there's a whole lot of TBI and PTSD in that community. It does seem like a lot of, and I'm loving this bit. There's a lot of what we're talking about is accessing the humility that we come to do the work with, and instead of necessarily doing things that are active, creating an environment where the person gets to be in their path. They get to be walking along their natural route to the recovery that's calling them, right? So I guess what I would like to do is ask, how do you guys see yourselves engaging the conversation with colleagues who maybe aren't in your discipline in a routine kind of way that allows the conversation to open rather than necessarily doing something active to make something happen, but just to engage that sort of natural, organic healing for the ranks? Thank you.
I would say living in and as the question. I don't have to do anything, and I never really think of myself as doing much. I'm more of a catalyst, and consciousness is kind of speaking through me. And sometimes if I don't even know what the words are, I just ask, all right, universe, let the words come out of my mouth. So I don't have to really do much. But it's engaging, really engaging and connecting with someone and listening and asking questions. You know, what do you think about this? What does this mean to you? And then if I want to offer a different perspective, well, have you thought about that? Well, what about this? What about that? You know, and just using the question as the instrument to invite a different possibility.
Well, you didn't ask a question, but it was profound what you said. What I found over the years working with populations like the reservations or the veterans is they do well many times with telehealth, even if they don't open the frame. They just hear you. But with that and the day-to-day services and working with patients, what I know personally in my work and my staff, 5 of them that are LCSWs and brain spotters and EMF, is they know that when they come and they're working with someone, because everyone is of value, is the experience of feeling safe and to develop an attunement with that individual will really help support a successful outcome. In this book that you cannot buy, that I provided over 150 in this room, they're in that white envelope, is Defining Mental Health. On page 16, Dr. William Glasser says one of the largest contributors to the mental health issues is a lack of quality relationships in your life. But unless you're healing, or you know, we're always going to heal if you have a lot of trauma, but to a relationship where people are engaging and well enough to understand that you're holding a capacity, and maybe they can too, and maybe not, is that space that we create for them is one of perfection, but they're really in the lead. And even if people look at us as, well, you know, human beings are imperfect, we are perfect spiritual beings at all times. So I just wanted to share that.
Just briefly, you know, thank you so much for that. And you mentioned the word humility, and it's not a word I actually use to describe myself at all. I'll just own that. That's a true story. But I had what you're speaking to, or what I heard you say, which is always interesting. I actually, 12 years ago, or whenever it was I started in this field, I did feel like I was kind of pushing an agenda or pushing against a system, and felt not seen. And I recognized for myself that was really my own trauma. That was my own trauma. I grew up feeling not seen. So as I continued doing the work and I continued seeing the profound results, there was a shift that happened within me, and I realized, oh, I don't need anyone to get this. I just need to continue to know that this is my truth and this practice. And then what happens is we've seen such a dramatic shift. My guess is 12 years ago, this panel wouldn't be sitting up here. right, in having this conversation. And it feels like we're at the precipice of this great change where actually a lot of us are coming out of the closet. I've actually had therapists say to me, I read Conscious Recovery, and oh my gosh, that's what we've been saying behind the scenes but have been afraid to talk about. And I had, when I first started working in this field, I've had people say, oh, you're that woo-woo stuff, right? I know because of your music and the beads you wear in your hand, right? So there is a profound movement happening now where we're integrating all these different modalities. And for me, I hold a space of that all the modalities have a place and a space, right? I'm just offering one perspective here, and there are more and more of us now that are free to begin to shift this conversation. And not that this way is right or this way is wrong. I hope no one hears me saying that, because it's all valuable for us. But to a truly integrated approach, again, is bringing the different modalities together.
Okay. I heard I love you so much, Dr. Smith. That's the Papa Bear there. Make sure I'm not out of line. So there was someone who said something about, I don't know if they used the words minority or what, or African American or Mexicans or something like that, about the difficulty they had in, getting successful treatment. So here's the deal. There is a woman named Joy DeGruy-Leary. She wrote a book called African American Slave Syndrome. If you work with the African American men, I want to suggest you read that book. It is profound research. She trains at Harvard, Yale. She's a consultant to the White House. But I mean just over the map with African American community, and there's other needs that we normally wouldn't think about that she talks about in that book. And if she comes to town, I think you have a 2-hour window to buy your tickets because they'll sell out. She is phenomenal. Okay, that's all I have to say. The name of the book is African American Slave Syndrome. Huh? Oh, Dr. Joy DeGruy. Look, I'm almost 70, y'all. I'm doing really good right now. Dr. Joy, God dog it. DeGruy-Leary, yeah. There you go. Right. And if you can come get the rest of these things inside, there's a lot of stuff.
Let me close it and turn it over. Yes. So we're finishing up our panel. Thank you so much. And thank you, Dr. Smith, for bringing us together again. And the messaging here is really about choosing compassion over being right. And the moment that we think that we are better than someone else is the very moment that we fail. And I think that panel, we just demonstrated how to access that thinking and bring it into our space with patients, clients. Thank you.